are now live. Welcome everyone to today's session. We'll get started in just a few moments, but in the meantime, please share who you are and where you're joining us from in the chat. And please also take this time to make sure that you select your language. To select a language, please click on the bottom where you see the globe icon, and it will take you to the English or French channel. And then you can mute the original audio. Everyone needs to select a language to ensure that you're able to listen to all of our speakers. We've also just shared a few poll questions that we encourage you to respond to while we wait for others to join. They'll appear on your screen now. If you'd like to read these questions in French, the French translation will be added to the chat box. And as you'll note, that the questions are in both English and French on the slide. The answer choices are in both English and French in the poll. Thank you for joining today's session. If you're just joining us, please add your name and where you're joining us from to the chat box. And please also take this opportunity to select your language. To do so, you can select the globe icon at the bottom, and it will take you to the English or French channel. You can then select which language you'd prefer. You can also choose to mute the original audio. We've also shared a few poll questions that we encourage you to respond to while we wait for others to join. If you'd like to read these questions in French, the French translation has been added to the chat box. And as you'll note, the questions are on the slide in both English and French, and the answer choices are in English and French in the poll. Thank you again for joining today. We're going to go ahead and get started, and I want to welcome everyone again to today's session. My name is Brittany Getch. I'm a program officer on the Knowledge Success Project at Johns Hopkins Center for Communication Programs. Knowledge Success is excited to be partnering with FP 2030 on this series, and this is our 12th conversation in the Connecting Conversations series. If you've missed previous conversations, you can watch the recordings on FP 2030's YouTube channel, or read blog post recaps that include recording links on the Knowledge Success site and get up to speed. This conversation will last for approximately an hour, and we'll have an open Q&A discussion with our three speakers. It's being simultaneously interpreted into French, as I mentioned, and it's being recorded in both English and French. The recording will be available in the coming days. If you haven't already done so, please select your language by clicking the globe icon at the bottom of the Zoom screen. It will then take you to the English or French channel. You can then select to mute the original audio. Everyone will need to select a language to be able to listen to all of our speakers. And participants are muted throughout the duration of this conversation, but if you have questions for our speakers, please type them in the chat box as you follow along. My Knowledge Success and FP 2030 colleagues will be moderating the chat box and will get to as many questions as time allows. Just a little bit about this Connecting Conversation series before we get started, in case you're joining us for the first time. Connecting Conversations is a series of discussions on adolescent and youth reproductive health, hosted by FP 2030 and Knowledge Success. We'll be co-hosting these sessions every few weeks on a variety of topics, but this is not your traditional webinar series. We're using a more conversational style, encouraging open dialogue, and allowing plenty of time for questions. The series has been divided into 5 themes. Our first one, which focused on a foundational understanding of adolescent development and health, started on July 15th and concluded on September 9th. And our second one, which started on November 4th and concluded on December 16th, focused on engaging critical influencers to improve young people's reproductive health. We're excited to continue this set of conversations with a discussion on what it looks like to implement an adolescent responsive approach. First, I'm pleased to introduce our moderator for today's session, Kate Lane. Kate Lane is the Director of Adolescents and Youth, where she works closely with FP 2030 countries that have made adolescent-focused commitments to advance evidence-informed approaches to improve adolescent use of contraception. Kate also collaborates with FP 2030's Youth Engagement Manager to support the work of youth focal points and to strengthen the Secretariat's capacity for meaningful youth engagement. Kate has over 30 years of experience in adolescent sexual and reproductive health and has worked on both the implementation and donor side. So welcome, Kate, over to you.
Thanks, Brittany. And as usual, we have a really diverse group of participants from around the world. So delighted to see you all wherever you're calling in, whether it's from the United States or Asia or Africa. I see a lot of friends in the chat. So great to have you here with us this morning, this afternoon, or this evening. And we have, of course, assembled 3 really dynamic participants who are going to talk us through some aspects of adolescent responsive service delivery. Our first panelist is, just a minute. Our first speaker is Aditi Mukherjee, who is a policy engagement coordinator at the YP Foundation in India. Aditi, who I worked with closely in the development of the Adolescent Responsive Contraceptive Services High Impact Practice Enhancement, is a queer feminist development professional from New Delhi. And as a policy engagement coordinator at the YP Foundation, she is involved in facilitating young people's capacity building and participation in policy development and implementation on issues of sexual reproductive health and rights and gender. She anchors the National Policy Working Group of young leaders and activists to support their long-term engagement in health policy development and implementation in India. Aditi also coordinates and supports the organization's engagement with government officials, particularly in the Ministry of Health and Family Welfare, and works with other civil society organizations to ensure meaningful youth engagement in various platforms and initiatives in the areas of sexual and reproductive health, adolescent health, and gender. She represents the YP Foundation as the global focal point on SDG 5, which is gender equality, in the UN Major Group for Children and Youth. She also represents the YP Foundation in the Partnership for Maternal, Newborn, and Child Health, and in the UN Economic and Social Commission for Asia Pacific. She has a keen interest in issues of bodily autonomy, criminalization, and ability to consent at the intersections of queer identities and rights, adolescence, and health access. So welcome, Aditi. We also have with us Dr. Josephat Avose, who's the Regional Program Manager in Adolescent Youth Sexual and Reproductive Health with the Challenge Initiative, and he is based with IntraHealth in Senegal. He has more than 25 years of experience in the promotion of adolescent and youth sexual and reproductive health and family planning in West Africa. He joined IntraHealth International in Dakar in 2018 on the Challenge Initiative and currently holds the position of Regional Program Manager for Adolescent and Youth Sexual and Reproductive Health for Francophone West Africa. He's knowledgeable in the provision of appropriate adolescent youth sexual reproductive health services, communication, and meaningful engagement of youth in transforming the socio-political environment of AYRH program implementation into an enabling environment. He's a doctor in developmental sociology and holds a master's in public health. Also holds university diplomas in epidemiology and health statistics and a state diploma in nursing. And I met Dr. Josephat last year at FP 2020's last Focal Point workshop, which was held in Dakar. He had a great session with us. And then finally, we have Inonge Winechinyama, who is a senior advisor on youth and disability at MSI Zambia. Inonge is currently providing technical support to service delivery teams which support access to contraception for young people and also persons with disabilities by ensuring that services are safe and non-judgmental. She uses evidence to inform programming and reduce policy barriers in in accessing contraception and to inform programming. She has 14 years of experience in marketing management, which includes 7 years working in sexual and reproductive health promotion. She's committed to being a conduit for girls who traditionally haven't had access to reproductive health options. In 2019, Inonge was invited by the World Health Organization to provide technical assistance in developing standard operating procedures for an adolescent and youth sexual and reproductive health and rights technical assistance coordination mechanism through the WHO Family Accelerator Project. Inonge holds an MBA specializing in marketing from Edith Cowan University, Australia, and a master's in corporate communications from the University of Zambia. She recently completed the Geneva Foundation for Medical Education and Research course on adolescent sexual and reproductive health. So great to have all of you with us this morning to talk about adolescent responsive service delivery. And we're going to go ahead and start with posing a couple of questions to our participants here, or to our speakers. And one of the things we've been talking about in the last, what we've been talking about in the last couple of sessions has really been how we are beginning to transition from this notion of youth-friendly services to an adolescent responsive health system, which is a much bigger concept than just providing youth-friendly services. And to me, it implies a degree of intentionality and being proactive in trying to address the sexual and reproductive health needs and preferences of young people around the world. So, but what we need to do now, going from this sort of big concept of adolescent responsive health systems, is to start to drill down and figure out what that means in practical terms at that nexus of where a young person encounters the health system. And so I think the three of you are well positioned to help us talk this through a bit more and help us really understand the nuts and bolts of what it means to be more adolescent responsive and take more of a systems approach. So the first question I want to pose to all of you is, what do you see as some of the main differences between implementing a systems approach to adolescent service delivery versus some of the current approaches that we see that are still commonly used, such as youth corners or specialized service delivery options? Maybe I'll start with Josephat. Dr. Avose, perhaps you'd like to talk a little bit about that based on your experiences with the Challenge Initiative. Sorry to put you on the spot. You're muted, Dr. Josephat.
Can you hear me now?
Oui.
Thank you. I'm very honored, and I'm proud to be the first person asked to respond to this question, but it's truly an honor. Thank you very much to those who organized this meeting and who wanted to, also thanks to IntraHealth and to all those who support this conversation. So we're talking about what are the differences between these isolated approach and approaches that are responsive to young people and current approaches. So let's look at current approaches, which are more general approaches rather than youth responsive ones. We need to start by recognizing that isolated approaches for services and that are dedicated to young people in slightly specialized centers, they exist so that we can better understand what are young people's needs. So that's quite important. So isolated programs have played a very important role. And so now we're moving into this transition period. So we've been able to develop knowledge about young people's needs. We've started to better understand their diversity. And now we can move towards more system level approaches that is going to encourage a care that implements the needs of young people and adolescents. I'm going to start by giving you an example. So we have an adolescent who can go into a supermarket to buy everything that he or she needs. Then we can go and buy, or they can go to a market where they can buy meat at one place, onions in another place. They can go somewhere else to buy pasta. So that's a bit the system that we have right now when we're looking at adapted services. So we need to have all of the same services or all of the many services they need in the same place so that young people can go and all of their needs will be taken care of in this one place. So when we're talking about responding to these needs, we're looking at different stakeholders who are involved. So when we get to a town or a city, and we go in order to help this municipality develop its approaches. And we take two approaches. The first is that we look at all of the needs of the city. So we look at a general level, and then we look into more care services, and we look at all of the different stakeholders and actors who are involved in this. So we have a strategy that is based on 3 pillars. First, we are looking at PPS and how do we implement adapted services. And we're trying to look at all of the people who are served by this facility. And then we look at those who are taking care of safety. We're looking at the guardians, we're looking at drivers, we're looking at everyone who is involved in providing these services. And these are people who are not necessarily often thought of when we are thinking about services, but they have a very significant positive or negative effect on young people's access to services. So we need to really consider every element of this situation, as well as every player, everyone who has a role, particularly in presenting services to young people. We look at the young people themselves, associations, and other groups that are involved in health centers. Then when we get there and we've done this analysis of all of the different players and all the different levels, then we look at the issues related to quality, confidentiality, judgment, and things that can be encouraging or discouraging. We look at stigmatization, and discrimination. So then we look at all of these problems and we look at them within each category. So even for drivers or caretakers, they have a role that they are playing in responsive services. So then we work on training, and we look at 5 different elements. So we look at age, civil status, equality, religion, and we try to look at all of these different elements. So these are just some examples of the things that we look at. Then we work with service providers to help them develop and learn how to provide non-judgmental and non-discriminatory services. This has a really positive effect on working with young people. if I am in a training with service providers, often I talk to those and I ask them about working with young people, and they say that's a completely different job because it requires so much more attention. It's very much out of the ordinary for us. So we are putting together training sessions that looks at the attitudes of service providers, and then we implement a support plan. And there are several elements on this as well. So we look at variation because we have different service providers every month. Then we have supervision of the providers. And then we have a mechanism in order to recognize and reward the efforts that these service providers have made. So first, I talked about recognizing the role of every person in the service provision system. And then we talked about training. And then we implement a quality assurance. And this is one of the most important pillars of our work. So we have several elements in this. We look at specific evaluations of service providers. We evaluate the services themselves. We evaluate the welcoming and the attitudes presented to young people. And then we also look at biases. So we look at the biases of service providers all the time, but we don't often talk about the biases of administrators. And so the administrators often are carrying these biases with them. So they're saying things like young people are too young, they don't know anything, they're too small. And so they're saying we don't necessarily have to work with them. And that's not true at all.
Thank you.
So we need to make sure that we encourage them to keep going. I'm going to finish soon.
Okay.
So if you ask me about presenting adolescent responsive services, these are some strategies that we use. These are 3 strategies that we use in order to make sure that we can provide services that are responsive to youth needs. There are so many other things that we could be doing, and other questions that we could ask that will let us go deeper into details. If you'll just give me one more moment, I have one more thing to say.
Okay.
When we're talking about a system level approach, we need to make sure that young people are able to benefit from all of the services available at a center. And we need to make sure that we are responsive to their needs at a systems level. We're talking about specialists and specialists who are in the center. We need to make sure that young people have easy access to contraceptives, and these global approaches, general approaches, are going to allow us to do this and to make sure that young people are able to benefit from all the services offered at a center. Thank you very much.
Thank you. Thank you so much, Dr. Vose. A couple of things that really struck me was, one is this notion is we've been doing youth-friendly services, and we're really beginning to learn from what we've done with youth-friendly services, and that's helping us to evolve to this more systems approach, and understanding that young people have multiple contacts with the health system, from the drivers, from the security guards, from the registrar, long before they actually reach the trained provider. So needing to see that the entire facility is friendly and supportive, and that the whole system is responding to the needs of young people. I think that's a really important evolution that we're beginning to accomplish. I wanted to pose a similar question to Aditi, because when we were working on the youth-friendly services, the adolescent-friendly contraceptive services brief, we had a lot of discussion about adolescent-friendly services versus adolescent-responsive contraceptive services. And we settled on this notion of adolescent-responsive contraceptive services exactly for that reason, that we wanted it to be seen as a more systems type of approach as opposed to a standalone youth-friendly service delivery. So Aditi, maybe you could talk us through a little bit more about how sort of the conversations we had about making this more of a systems approach to service delivery.
Thanks, Kate. Thank you for having me. I'm really honored to be speaking at this platform. As Kate mentioned, we worked on a HIP enhancement brief on adolescent responsive contraceptive services. And the way that we went to adolescent responsive instead of adolescent-friendly contraceptive services is that, and like Kate mentioned, it implies more of an intentionality. And it also implies a more macro level approach to adolescent responsiveness. A systems approach basically means that the larger health system as a whole has an adolescent lens to it. To me, what that means is that even if we're approaching thematics like, say, mental health or gender-based violence or queer identities and policies related to them, we incorporate an adolescent lens to them. Instead of thinking of adolescent health as a whole separate other thematic, we're including an adolescent lens into all of the policies and programs that we are initiating. I'd like to take an example of a specialized approach, which I've personally worked with, which are specialized clinics for adolescents. In India, we call them adolescent-friendly health clinics, or AFHCs. We've had specialized clinics as a whole have had some mixed successes around the world. In India, we've seen very little success with these clinics. One of the primary reasons is the limited amount of human resources and other kinds of resources that are available to these clinics. These clinics need a dedicated adolescent health counselor. So if you don't have a counselor, you don't have a functioning clinic. If we incorporated adolescent health as a thematic within the larger health system, and trained, as Dr. Josephat mentioned, the different points of contact that adolescents have within the health system on adolescent friendliness, on respectfulness, on how to treat adolescents, then the situation would be very different, because you'd have a larger cadre of resources, of human resources and other kinds of resources, who are trained on how to handle adolescent health. This is especially important when we're talking about reproductive health and family planning in particular, because these kinds of specialized approaches make it more difficult and stigmatize adolescents more when they're approaching these kinds of facilities, because it's harder for an adolescent to go to a clinic where the implication is that you're going for planning service. So if you're going to a hospital just like everybody else, that stigma is removed. The other difference that I think is in the other kinds of thematics that we have. So if we're making a mental health policy, it's better to have a larger mental health policy with an adolescent health component built into it. It's easier, and it takes up less resources, and you work with the resources that you already have, as opposed to making a separate adolescent mental health policy or program. So I think specialized interventions have worked in some cases, have had mixed successes, such as specialized clinics. But I do think that going forward, it's in our best interest and uses less resources and gives us better results if we incorporate an adolescent health lens into the larger policy system as a whole. And I think we, as policymakers, as members of INGOs, as service delivery people, it's our responsibility to ensure that we're taking in the input of adolescents into these systems. So an adolescent responsive system, by its definition, is responsive to the needs of adolescents. So this kind of system also builds into it a responsiveness to the feedback that adolescents give. That's not always the case with adolescent-friendly systems, which imply the kind of treatment we're giving to adolescents. But an adolescent responsive system means that we're taking their feedback into account and providing accountability and making changes based on the issues that they've raised. So I think the difference between these two approaches is, again, reiterating what Kate said, intentionality. And I also think it's a larger approach rather than focusing on smaller interventions and going on single interventions. I do think it's harder to do. I'm not going to say that that's easy, and given the situation that we have on ground, especially in low and middle income countries, it may seem like we're asking you to overhaul the entire system. But I think what we can do is like make small incremental steps so that when it comes back around that we're making new policies, we're making new changes to existing policies. This is something that we keep in mind, that we have to have an adolescent lens when we're making changes, making new policies, or even making a new intervention, so that we're not just talking about adolescent health as an afterthought. We're keeping it at the forefront and thinking about it when we're doing the planning phase. So yeah.
Thanks, Aditi. I've had the opportunity to talk to young people in many different settings, and they'll often say, listen, I know that the provider in the facility is friendly, she's well-trained, but I just can't navigate getting to the provider because I get, the security guard looks at me in a way that makes me uncomfortable, and when I register, they're not very kind, and they criticize me for being there, and it just, it's just really, really hard to get to that provider. Sometimes there's so many barriers and challenges, and so by being more systematic and thinking about these challenges, above and beyond things like cost and availability of, service delivery hours, I think these are important. Inonge, I think you have some really interesting experience because of the work that MSI has done in Zambia with what were formerly the DIVA centers. And I think that there's been some transition from these kind of specialized programming to a more sort of systems approach and working with the public sector. So maybe you could give us some insights into what MSI has learned from this kind of transition.
Thank you so much, Kate. I hope everyone can hear me. For some reason, our internet is sort of quite bad today. But yes, I'd like to share our experience with the DIVA centers of how we've evolved from standalone centers into public sector strengthening. So around 2013, 2014, Maristop, Zambia, we realized that our adolescent numbers were not as great. We were around 7% of the adolescents, that of the total population that we are seeing were adolescents. And this was very, very low. And we realized we needed to do something about our adolescent work. And so we went into research mode to try and design what is it that adolescents want? How do they want us to present SRH to them? And so we designed the DIVA centers. And these are standalone clinics or special clinics where we are providing contraception to girls. And our primary target was girls 15 to 19 who are unmarried and do not have a child. And the design was really great. We had young people who were the face of the DIVA centers. We had demedicalized the DIVA centers in terms of messaging, in terms of the feel, in terms of the experience. We had the greens and the reds in the DIVA centers and so on. It looked really nice and bright, and the feel is really, really great. And even in terms of successes, we had about 93% of girls who are coming to us were aged between 15 to 19, and about maybe 50% of them were unmarried and in school and without a child. And this was really great. And about 80% of the girls who came to us left with a contraceptive method. And this was really, really nice because they're like, oh yes, finally we've gotten the profile that we need, the profile that we've always left out. And so we began to scale, like, okay, we've gotten it right, let's begin to scale. And so we began to plant DIVA centers around Lusaka in Zambia. And then later we realized, oh my God, this is a very expensive model to scale. And so the important things began to come, like cost. It was too expensive. You can't go around the country planting standalone centers for girls. Secondly, we couldn't scale it. It was a beautiful model, but we could not scale it. Thirdly, we could not sustain it. And those are critical things when you are talking about impact. You need to mind the cost, you need to mind the scale, you need to make sure it's sustainable and you can iterate. And we couldn't do that because of the design of the model being very expensive. And so then we went back to the drawing board and began to think, how can we embed the DIVA lessons into government structure. If you're coming from a country like mine in Zambia, health services are predominantly provided by government. And so they see the largest number of young people. And so if you want young people to access services, you have to capture them in the government system, and it is free. So then we began to think, like, what elements can we get from the Diva Center, which we can get into public facility? And so we got some of those designs and then took them into service delivery at government facility. One of the critical things that we did was that instead of having our own providers as Maristops, we'll use government providers. That reduced the cost. Instead of having rented property to provide services as a standalone special clinic, we were using the government facility, no rentals. So we reduced the cost in terms of rentals and operational costs. Commodities, we did not have to supply commodities as Maristops. We were able to use commodities within the public sector, within the same supply chain, within the public sector. And so those were the critical things that we got. And so looking at a standalone or special clinic or youth corners, they're quite expensive to maintain. You can't scale them. They are not as sustainable. When you have good funding, we had very awesome funding from Hewlett Foundation, which was really great. And it supported us for a number of years, about 5 years. But the challenge is that when that funding comes to an end, then service delivery ends. But when this is embedded into the government structure, into a systems approach, even without funding, services still continue. And so this is now what we're currently doing. I know, Aditi, you've talked about how hard it is. And yes, it is hard to get a systems approach. But I think what has helped us, the lesson that we've learned, is that we're not looking for immediate results with adolescents. It's long-term. It's continued advocacy with government. Let's continue to advocate at every level, at facility level, at district level, at provincial level, at national level. We continue to advocate that we prioritize adolescent health and not expect very immediate results. Or we put in so much money and we're expecting this much money. They're young people, they change every day. They don't come in hundreds. They trickle in to get a service. Okay. So all those things have to be sort of managed. And that was a great learning for us to move, to evolve. So our Diva centers are still there. We have one center, but it is now our lab. It is our center of excellence for learning. But in terms of scale, we've scaled all the learnings that we've done into public sector. Thank you.
That was a great overview of MSI's work. I really encourage everyone who is participating to drop your questions into the chat box. We intend for these sessions to be conversations not between just the four of us, but with all of you as well. So please do feel free to drop a question into the chat box. The next question I'd like to pose to our distinguished group here is, in our last connecting conversations a couple of weeks ago, we talked about the diversity of young people and recognizing we've been talking about this for many, many years, that young people are not just a monolithic block, but they have a lot of diversity in terms of their needs and experiences. And how do you account for the diversity of needs, do you think, when we're trying to implement more of a systems approach? So I don't know who'd like to take that first. Anybody? Volunteers? Yeah, Dr. Josephat? You're muted. Wait.
Thank you. So-called global or adapted approaches that are being discussed today are based on meeting the needs. This is fundamental. Then needs have to be seen, perceived, analyzed as a whole rather than in their diversity. That is an important distinction. The specific adolescent and youth groups are not neglected when we take into account or when we put in place adapted services, be they a group of disabled youth or groups of street youth or group of drug addicted youth or underprivileged groups, everything is taken into account precisely because of this. We have 5 key elements that allow us to answer this question, how to take into account and meet the needs of the specific groups. First, a systematic identification of the needs of youth and adolescents, not simply for family planning, but for everything. Young people have full packages of services. They have unlimited needs, sorry to say that. So, but what are the needs on which we can intervene and do something? How can we identify a method to meet those needs? The second point is training of service providers and other stakeholders on how to take into account these needs. The third point is we need to understand that demand creation activities are not dissociated from services that are offered. When we're looking at offering adapted services, there is a connection between the two. And this allows the patients that were referred to easily find the right specific groups and connect them with the services, health services they are seeking. Some needs are highly specific. For instance, young drug addicts. So they need to be rehabbed, they need to be placed in centers to be detoxified. So we need to offer advanced strategies or mobile strategies to be able to meet those highly specific needs of youth and adolescents, such as the disabled groups or those that are in jail. So global approaches must be adapted and cannot neglect the specific groups. On the contrary, they take them into account. When we took when we look at the free resources that are distributed to those who can't afford them, all this has to be thought through together. When we look at the grid I mentioned earlier, we reviewed all of this. And when we're ready to put in place adapted services, the point is not to extract a need out of the whole range and see how we can deal with it. No, we take the young people, the groups of young people, and then we see what their needs are and see how we can meet those needs. And then it is integrated in the strategy. This is how it works. And these are the 5 points I wanted to mention to see what we're doing in French-speaking Africa to ensure access of youth in general, but also specific groups of youth to adapted services of sexual and reproductive health.
Aditi or Anonge, did you have anything you wanted to add? Aditi?
Yeah. Sorry, Anonge.
You go.
Okay. I think when we're talking about diverse needs, I think it's important to take ourselves out of the equation. We are not people who are affected by adolescent health programs or policies. We're not beneficiaries. These are not programs designed for us. So I think in that way, it's important for us to speak directly to adolescents. We need to utilize spaces in which adolescents are able to safely provide input. If such spaces are not available, we need to build them. The other thing I think that we need to do is to make sure that that systems intrinsically push the need to identify diverse needs, which means that adolescents are present in every stage of a policy or a program. So from planning, from ideation to implementation to monitoring and evaluation, adolescents are present, so that even if we as people who are from on the outside of the problem, we can't see a particular need, the people who are actually affected can provide that input back to us. The other thing that I would like to say is that our current system, at least in India, does not recognize the diversity within adolescents or young people for that matter. But an adolescent responsive system does ask us to do that, but we have to ensure that that kind of diversity is recognized and institutionalized within a policy structure. So if we're saying that policy programs recognize the diversity of adolescents, we need to put it in as explicit terms as possible. So because too often what policies do is that they refer to all adolescents, but in practice, they're obviously not talking about all adolescents. They're talking about the most normative model of an adolescent that policymakers come up with. And if you're an adolescent who does not fall into that model, your needs are not going to be met. So one of the things that we've discussed in the HIP brief as well is are the barriers that come up for adolescents who are outside of this normative model have to access contraceptive services. So our role as policymakers and as people who work in the sector is to ensure that we're looking at those barriers and seeing how we can remove those barriers so that we can get input from adolescents. Another thing that I think we haven't had a chance to discuss is the need for disaggregated data. So once we have better data, once we have better input from adolescents, that's how we're getting, that's how we get better policies and better programs. So right now, our data is very well limited to pockets where where feedback is collected well and places where it's not. So I think the collection of data and the disaggregation of data is also something that we need to institutionalize to get better feedback from adolescents. And I think if we institutionalize that, we are automatically getting at least some points of reference for what adolescents need in a community. So I think those are the three things that I wanted to say. Apart from that, I do agree with what Dr. Josephat has been saying.
Go ahead, Anonge.
Yeah, sure. Thank you, Kate. And definitely agreeing with my two colleagues. What I wanted to add is that I would like to speak for Zambia or for MSI. We have an approach called human-centered design that we use. And with human-centered design, it's about working with the people you are designing for. You cannot design anything without the people that you are designing for. And so it's very critical to ensure that at design stage, we actually involve young people to be part of the design process, to be part of the implementation, to be part of the monitoring, to be part of the evaluation. And so that is really, really critical. And as everyone has said it, once you get adolescents to tell you exactly how they want an intervention to be presented to you, you definitely get it right. Sometimes what we've done is like asking any one of us to say, oh, can you please give a present to Inonge? It's her birthday. You will not know what to get from me unless you talk to me. What is it that Inonge likes? What would she appreciate as a birthday present? And over time, we've just given presents to adolescents without asking them what is it that is really important to them. So human-centered design is very critical, or understanding adolescents is really critical. But beyond that also is that we have learned as MSI that much as we want to involve adolescents, if you're talking about system strengthening, you need to involve the system, the people working within the system themselves. So if you are designing something to be embedded in a system, then the people who are using that system also need to be talked to. So we've also done human-centered design for government providers. You know, like how do you work? How do you think you can incorporate adolescent priorities in the system that we have? What do we need to change within the system to make this work? And while doing that, so you build capacity within government providers, you build capacity within the system, but also you do some sort of a values clarification training, which we do, because remember, we've always spoke about provider biasness in government. And young people need to understand that, oh, now we can trust the government providers, you know. So such kind of learning needs to happen within government. Like, can we build credibility within government so that a young person can actually trust us, you know, can trust the government or the public facility to say, I can actually go there and get a service. The second thing is the integrated services. If you remember youth corners, or clinics were only focusing on HIV at some point, and we assumed that was the only need for young people. But now we need to be very holistic. What is currently happening in Zambia, we've got different areas that we're looking at: HIV, SRH, mental health, nutrition, and many other things. So these services are integrated within the facility so that young people with diverse needs can actually get a service from there. Another issue which we need to look at, a very marginalized group, is adolescents with disabilities. We've always assumed that they are not sexual beings because they've got a limp, because they've got a problem with hearing, or because they cannot see, then they are not sexual beings, or they don't have the needs that we have. They do. And we need to learn that we need to understand these adolescents as well and how they want interventions to be presented to them by working very closely with organizations for persons with disabilities. The other issue that I wanted to talk about is the difference between rural and adolescents in urban. They're very different. And so for a rural adolescent, they do not really work in a vacuum. They've got the whole community that is around them. And so if you're going to provide an intervention within the community in a rural setup, you need to understand who are the stakeholders, whom do we need to talk to, so that that young person can actually walk to any place and get an intervention without feeling intimidated by the community. And so those diversity of stakeholders needs to come into play as well to create that enabling environment for a young person to actually access a service, even in the health system. If this is not sorted out, we can have the best of health systems and young people will still not come because the environment has not been created for them to feel safe to actually go and get a service. Thank you.
Thank you. And Inonge, we're getting a lot of questions about the work of MSI and the DIVA centers and how you managed to transition the sort of these approaches to the public sector. And there's one question that I found interesting here is how are the staff that you're working with in those public health facilities, how are they responding to these new approaches that you're introducing, you know, because of the questions we often, or the concerns we often hear about the biases of providers. My own experience is that oftentimes providers would like to be good providers, but they don't always know how to do it. So maybe could you talk a little bit about how you've been able to work with providers to begin to address those biases, and then also invite Aditi and Dr. Josephat to comment as well. But we'll start with Inonge.
Yes, sure. Thank you. So there was a lot of advocacy work that went into what we were doing. So it wasn't just a matter of saying, oh, okay, here is the design that we have and we're bringing it into public sector. But we had to do a lot of advocacy work from the national level, provincial level, district level, and facility level to say, this is what we bring to the table. And we had to align the priorities of government with what we're bringing. If anything does not align with what is a priority to government, it becomes a problem in terms of buy-in. So we needed to look at what are the guidelines around adolescents. If we are designing something, are we aligning with the government policies and the government guidelines around adolescent health? And all these things that we're doing, we ensured that they were meeting the objectives that for government. And we're saying, look, these are the objectives that you have as government, but we just bring a nicer way of achieving these objectives. That was one, which was very broad, like the advocacy thing, which was really broad. The second thing was allow government to lead the partnership. Sometimes as civil society, we're like, oh, we are experts, we know it all, this is what we bring, and it doesn't work that way. So allowing government to lead the partnership is very, very critical. And also ensuring that each one knows their roles. What is the role of civil society? What is the role of government in what we're doing? So those responsibilities have to be very, very clear in making things work. The second thing was training, building capacity within public providers. Kate, you've said that sometimes providers think they're helping, you know, like they thought, oh, like I was just helping, but you're actually becoming a barrier. And so we've got a values clarification and attitude transformation training that we do to all our public providers when we begin to work with them. This is a training around our values and our attitudes, and how can we ensure that the values and attitudes that we have are not a barrier to service delivery. We are not saying, with this training, we're not saying change from who you are. We're saying, can you step back? It's not about you and your values. It's about this young person who's come to you to get a service. And it's not a very easy training, because it's values that you hold dear to your heart. It's values that you've had for the last 40 years, 50 years. And suddenly someone is saying, this is the acceptable way by young people to do it. So it's a very progressive training, which we keep doing, we keep revisiting and so on. And that has really helped in making sure that providers can actually challenge their own values and see that sometimes their own values can actually be a hindrance to the process. But however, I think what we've also done to ensure this is happening is creating champions at every level. So at national level, we've got our champion, who is the director of adolescent health. At provincial level, we've got champions. At district level, we've got the district adolescent focal point persons for the district who champion adolescent health. At facility level, we have them as well. So we've ensured that we've brought these people together with us and had a training and had honest conversations about data. Aditi talked about data. These are the numbers. This is how bad we are doing. This is how we've struggled the last 10 years in adolescent health. But we can do things better if we're looking at data, looking at the gaps, looking at new ways, looking at innovation on how we can do things better. So yes, Kate, there's been a lot of conversations to make this actually work. Hard as it may sound, but once that is done, it becomes easy because then you are on the same page with government and you're beginning to see the same vision and working towards the same objectives. Thank you.
Thank you, Inonge. And I'd like Aditi from the YP Foundation perspective also to weigh in from the perspective of young people. And just to let people know, we are approaching time, so if people are okay to stay on a couple of minutes, I'd like Aditi to respond, and then we'll have Dr. Avose wrap up as well.
Okay, I will try to be quick. So one of the challenges that we as a youth-led, youth-run organization at the YP Foundation have faced is that service providers don't really know what respectful and friendly and treatment is of young people and adolescents, especially when it comes to sexual and reproductive health. And so the first thing that we did in in our project, the Access project, is to go back to young people. I know I've said this before, but we went to a select group of young people in New Delhi. We asked them what they think is good treatment when they go to a doctor, when they go to a clinic. So we've made a tool which measures the kind of treatment they get from a medical service facility. So this is the tool which sees how friendly and how respectful a service provider is. So that's one very small way of seeing what youth friendliness means to one particular community, because it doesn't mean the same thing across urban and rural communities, castes, religions, etc. So it really, I know I sound like a broken record, but it's important to get adolescents involved in the conversation. If we as service providers and as policymakers have an idea of what constitutes youth-friendly or respectful treatment of young people and adolescents, and that doesn't match up with what they're expecting and what they think it is, then we are failing. The other thing that I would like to mention is accountability. Like Inonge mentioned, when we're conducting advocacy, it's important to go back to the government and say, okay, this point of data says that this is not working, this is not working. In our HIP brief, we mentioned Chile as a success story. The Chilean government has created, in their 10-year plan, created a legal framework that articulated stakeholder responsibilities. The Chilean government also worked with the Pan American Health Organization and UNFPA to create a Adolescent and Youth Advisory Council that works with ministry authorities on policies and health services which are geared at young people. They often work specifically on sexual and reproductive health, they have an emphasis on unplanned pregnancy though. This council, which is just for people who are under the age of 24, they meet with representatives from the Chilean Ministry of Health and they share their opinions, on what they think is working in their communities, what they think should be done. So this is a very direct version of accountability, in which young people themselves are coming to the government and saying, okay, this is not working, I want you to do this. In Chile, there's been a 51% reduction in the proportion of births to mothers under the age of 19 between 2000 to 2017. So this is one of the ways that we can be more responsive. So accountability is another extremely important thing that we're looking for. So again, ensure meaningful, sustained participation of adolescents and young people. And that's the only way we can do this.
Thanks, Aditi. And Dr. Josephat, I'd like to pose to you the similar question about taking these new approaches and embedding because I think in Francophone West Africa, most services are provided to the public sector.
Je crois qu'en Afrique de l'Ouest, cela a été
Have
fait.
been the public sector providers to
Je travaillais avec les
adopting
prestataires
these
de services
and
et on les a
TCI is
encouragés à
champion.
adopter cette approche. Qu'en pensez-vous? Thank you. I believe I understood there was some issue with the interpretation channel, but let me say that TCI intervenes in cities upon their request. Once we arrive, we accompany the system, be it through the health system as a whole, the stakeholders, the municipal authority, the youth. We help them implement adapted services. We had main strategies, the orientation and guidance of the professionals, training providers on quality of service and providing services. As far as accounting of goods and assets, we have a colloquium of truth where we clarify the values. So there are personal values and professional values. How can we avoid confusing the personal one and the professional one? Be it a pastor, a priest, the wife of the imam, the sister of the imam. So we need to meet with people, but when a young person meets somebody who's much younger, it's often difficult. So we try and clarify the values to make the distinction between personal and professional values. That's important. And as was said by my colleagues, the capital, crucial element is the participation of young people. TCI and French-speaking Africa is the promotion of young leaders for transformation purposes so that they can intervene at the level of every steps of the transition and transformation. People seem to think that the young people have nothing to say, but no, they do. That is not true. Our important element is coaching. How do we accompany the local governments, the health services, the municipal systems, and the young people? How do we accompany them so they can own tools, approaches in order to put in place adapted services? So coaching is a fundamental element of our strategy in order to make sure there is the right implementation of adapted services. We have other tools. Let me mention them quickly, two of them. First of all, the evaluation of quality and sustainability of interventions. That is what we call the RUIS. That allows us to determine in which way every person plays their part. So we can gauge the validity of approaches. The other tool I wanted to mention is citizen responsibility, accountability. We put together young people, providers, municipal authorities, management committee, community leaders, youth leaders, and we say, okay, you said you were going to do this. Did you do it? Yes. How? If not, why not? So it is really an accountability evaluation, and we see how to find solution to problems. And 1 minute to mention two more points. there are what we call the tool to support accountability. We create tables on the rights of clients. These are posted in every room so that staff can see them all the time. Second, there is what we call the charter for providers. It is a commitment made by providers to say they will abide by confidentiality, they won't be rude or insulting towards young people, no discrimination towards young people, so no value judgment. And we post these tables, these posters in the centers so that we are there to provide services and to pass on a service, but not convey our personal values or personal opinions. And the final element is supporting people in the decision-making process. We support cities when they're collecting data, and we support them in their review of the data on a regular basis at the level of the health center, at the level of TCIT, at the level of the region, and through the institutions that were put in place, such as the Management Technical Institute and so forth. So this is what we do to increase the accountability of providers and help cities and towns to put in place global approaches. So you understand that the implementation of a global approach is not a single intervention, it's a multiplicity of interventions that are conceived, that are built as a package in order to move forward, particularly to meet the needs of adolescent and youth and give them satisfaction. This is how we raise up, we eliminate obstacles. We've talked about structural, socio-structural, socio-cultural, and personal obstacles. If the services are not providing, eliminating these obstacles, they are not adapted services. If they help eliminate these obstacles, that will allow youth and adolescents to see their needs met. And needs are very diverse. We need to take into account also the more global perspective. I could continue, but I see that time is moving forward, so I will stop here.
Thank you so much to Dr. Josephat and to all of the speakers this morning, Aditi and Inonge. I'm so sorry we couldn't get to all of the questions in the chat box. There were a lot of great questions, really a lot of curiosity about how you all are implementing these programs, what are the challenges, what are the opportunities. To me, it's quite heartening that we are beginning to move away from these sort of standalone youth corners, youth centers, and really seeing the value of shifting and improving the quality of services that are provided through the public sector, since they are the biggest provider of services in many of the countries around the world. And that's where young people are going to be most likely to be able to obtain services. One last point I just wanted to make was, there was one comment that I think, we're talking about improving improving the capacity of the health system to better respond to young people. I think we also need to continue to keep in mind the more sort of the multi-sectoral aspect of young people and really helping the health system to be connecting to those other systems within the community, like education system, the employment system, sports and recreation, seeing young people holistically and understanding that these various systems need to interact almost like, cogs in a machine for more seamless interaction and referral mechanisms between all of them. This session was recorded and it will be posted on the website. Again, I'm so sorry we couldn't get to all the questions. Thank you all for attending and for staying with us. I see most of you have stayed with us this morning beyond the 8 o'clock hour. And we will be hosting one more session in this, there we go. There's our next session is going to be April 29th. And we're going to be talking about how do we work with health systems to evolve their services to young people as they grow and change. Again, thanks so much to everybody for participating, for your lively questions. We look forward to seeing you in a couple of weeks. Enjoy the rest of your day or enjoy your evening if you're piecing out. Thank you.